or obstruction. A lot of them have it because of chronic bronchitis. The diseases that fall under this category are asthma, bronchitis, bronchiolitis, pneumonia, emphysema, and congestive heart failure. Okay? Asthma, bronchitis, bronchiolitis, emphysema, pneumonia, and congestive heart failure. Make sure I got one. And what happens is this person has 2 or more of those diseases, okay? And they suffer chronically. So at any given time, at least one of them is going on. Typically, if they have emphysema, they just got emphysema. If they've got bronchitis, it comes and goes, but it's there more than it's not, okay? And what happens with those is excessive mucus production, obstruction of the small airways because of mucus plugging or trapping, which causes air trapping. And then the alveoli themselves start to suffer atelectasis because gas exchange is not taking place like it should. Okay. Emphysema is usually the disease that when people say they have emphysema, they probably have COPD. Okay? What happens with emphysema is the elasticity of the lungs themselves is kind of lost, okay? The alveoli constantly have to be stretched in order for them to breathe. And what happens is, because they stretch so often, the patient's lungs loses its elasticity. That happens because of smoking, okay? Or chronic exposure to chemicals. This is what used to cause those patients to end up in the old iron lung. Like black lung from coal and things of that nature. Okay, those are your severe COPD patients. Like I said, most patients that have it have elements of both chronic bronchitis and emphysema. So they've got the mucus buildup, they've got the tightening of the lower airway, they've got the elasticity of the elasticity loss of the lungs, and they always have inflammation of those airways. Always. Okay, you'll hear them and you'll see them. One of the things they do in order to try to get air to stay in their lungs is they're what's referred to as pink puffers. Okay? Okay? Yeah, pink puffers. Or excuse me, blue bloaters. Blue bloaters are your people who have walk around with pursed lips in an effort to try to cause their own PEEP. Okay? Pink puffers are your congestive heart failure patients. These people will have what's referred to as a barrel chest because they're constantly trying to keep that chest open in order to get the air to move like it needs to. But it's very difficult for them to get that air to move like they need to. Okay. This is just an idea of what it looks like. This is the inflammation of the mucus there. This is the obstruction that actually happens. This is just, like I said, inflammation, mucus buildup. This is obstruction due to mucus buildup and the infection / inflammation that's going on there. Okay. Now you see how big that alveoli has to get in order, or because of the fact that that air is trapping. So that CO2 is just building up in there, and it's going to cause them to become. It's going to cause that alveoli to become diseased. Okay. So patients with pulmonary edema will have what's referred to as wet lung sounds. They will have what we call crackles or rails. It's a very it sounds like a Rice Krispie when they're breathing. You'll hear that when they breathe. Patients with COPD have very dry lungs, but what you may hear sometimes is wheezing, okay, because of said air trapping. Okay. Sometimes if you listen to them, they can be confusing, but look at the signs and symptoms of your patients, okay? Your COPD patients with dry lung sounds that won't typically have elevated blood pressures, okay? But your pulmonary edema patients will. Why? Because they have excess fluid inside those blood vessels that's causing systemic vascular resistance, okay? You may have a patient in the early stages of CHF that does not have the wet lung sounds. Check the blood pressure, check the breathing difficulty, listen to the lung sounds, and keep listening to the lung sounds. Because if at any point, and like I said, if they have a history of CHF, or it's likely that CHF is the culprit. So if they're having that severe difficulty breathing, what we're going to do is we're going to put them on the CPAP. That way we can keep those lungs open, okay? And help to force some of that fluid out. That's probably one of the most important things we need to do, is force that fluid out, okay? All right. Then we have asthma, hay fever, and anaphylaxis. Now, all of these kind of run in the same gamut, okay? What happens in asthma is there's a tightening of the bronchi, okay? And specifically the bronchioles. What happens down there is, again, air trapping. The problem with asthma is not that you can't get air in, it's that you can't get CO2 out. And so because of that, this person is breathing, and breathing heavy, but they're having this characteristic wheezing, that very deep wheezing, and after a while what's going to happen is it's going to get so backed up, so built up with CO2 that they're going to go into cardiac arrest. Okay? A lot of times, and I've worked a 16-year-old cardiac arrest due to asthma, because she used her puffer like 30-something times in a day, and it didn't work. And mom didn't think it was pertinent enough to take her to the hospital. Okay. A lot of times asthma can be caused by an allergic reaction to food or allergen, not necessarily like anaphylaxis, but some sort of allergen. Like I have asthma, and I know certain times when I'm dealing with pollen, things of that nature, it'll cause tightening of the bronchi, it'll cause wheezing, it'll cause things of that nature. So we want to make sure that that's what we're treating the patients for, is the signs and symptoms that we're seeing, not we really can't treat for the allergen unless they're having an anaphylactic reaction, but we can treat them with albuterol, we can treat them with oxygen, okay? And sometimes this can be because of emotional distress. Somebody get worked up and actually cause themselves to go into an asthma attack. That is a very real thing, okay? So hay fever can cause cold symptoms, dust, pollen, dust mites, pet dander, this, that, and the other. Anaphylaxis is a very different animal. What's happening in anaphylaxis, for the best way that I can explain it, is what I like to refer to as the perfect storm. Okay? Anaphylaxis is two things happening simultaneously. You have the allergic reaction, and you have an asthma attack happening at the same time. The allergic reaction is what's referred to as an IgE, big I, little g, big E reaction, immunoglobulin echo. What happens in an IgE reaction is histamine is released into the body. Okay, and as the histamine is released into the body, what transpires is this fluid starts to fill, or the histamine is released to the body, it starts to overreact to the histamine response, and so the body starts to fight it off. Well, the way that it does that is bronchoconstriction, vasodilation. So what you have is you have the asthma attack that happens because of that. The bronchi and bronchioles are constricted, and the blood vessels dilate. So you have a drop in blood pressure, an increased pulse rate initially, a low pulse rate eventually, and you have severe difficulty breathing. Okay? This is what happens. And then what happens is, because usually this is an inhaled thing, the body starts to build up mucus in an effort to try to get it out. So it's literally fighting against itself to the point where it's almost, it is killing itself, okay? It's killing itself in an effort to try to fight off something else, okay? And that's why we use epi, because what epi does is, epi is a alpha/beta drug, okay? Which means that epi causes bronchodilation, vasoconstriction. So it does the exact opposite of what the histamine does, okay? When we give the EpiPen, or the dose of epi, 1 to 1,000 IM, we never give it IV. If we give epi IM, or sub-Q, into the musculature, what we're doing is we're causing the bronchi and bronchioles to dilate and the blood vessels to constrict. This brings the blood pressure back up, this brings the pulse rate back to a normal, and it or helps to bring the pulse rate back to normal, and it causes the lungs to be able to open so they can get the mucus out. What we have to do therein is assist them with albuterol, and probably for asthma and anaphylaxis now, one of our treatments is CPAP. because we want those lungs to stay open, and we want to get that mucus out, and we want to create as much gas exchange as possible. Okay, so that's what we're going to be doing. And the other side of that is, if they have Benadryl, we want the patient to take Benadryl. Or from the ALS standpoint, we give them diphenhydramine, or trade name Benadryl, and oxygen. And our oxygen, like I said, oxygen therapy for an asthma attack is CPAP in a severe asthma attack. Okay. All right. Any questions about that?
No. I do have a question.
Yeah.
It's kind of on topic, but not at the same time.
Okay.
In my area, we have a lady who is allergic to Haldol. Have you ever seen one of those?
It's not actually allergic to Haldol. She has a hypersensitivity.
Okay.
And she has what's called EPS, and you give Benadryl.
Yes.
Yes.
And I mean, we went to her, not me specifically the very first time, but a good friend of mine went to her, and it's in my area, so she was like, hey, this is kind of what's going on if you see it again, and I did the other day.
Nice.
What causes that though?
It's what's referred to as extrapyramidal symptoms. Haloperidol is a benzodiazepine, and what it does, it's a sedative of sorts, but it causes a if you have a hypersensitivity to that sedative, what it causes in your patients is it causes a extrapyramidal reaction. In other words, it causes central nervous system depression, and it causes cog-like motion of the muscles. And so that's where you get like the click, 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 click of the arms, or like the ticking of the jaw, things of that nature. That's what's referred to as EPS.
Okay.
And that's what you probably saw, was those weird motions she was doing, or weird reactions.
Yeah, it's almost like, I mean, the best way to describe it is like as if she was possessed.
Yes,
Or something.
that's exactly what it looked
The
like.
very first time they found her, she was actually laying in her bed. When I went to her the other day, she was sitting in her couch looking straight up.
Yep.
And I was just kind of wondering.
I had a patient that one time when we had a EPS, or what we got for a site call, and her response to the Haldol that we gave her was she had the possession type reaction, and she had the cog-like motion that you'll see and things of that nature, but she kind of lost it for a minute, reached up and grabbed the paddles off the side of the cardiac monitor. Yeah.
Wow.
So yeah, I was like, oh crap. So yeah, I mean, and what you do in that instance is you give them a different sedative, and you have to put them down. And that's what we had to do. We had to give her Valium in order to put her down.
Yeah, it's not that bad, but we give her Benadryl, and but yeah, I was just wondering. I haven't had a chance to ask someone.
That's a good question. It's a good question. Yeah, it's weird, and like I say, it was kind of freaky because when I called for orders, they were like, "Yeah, give her Benadryl," and I was like, "Benadryl, all right." They're like, "Yeah, trust me, just give her Benadryl. She'll be fine." One, Benadryl is a histamine blocker, and what it does is it causes drowsiness, and so gave her 50 milligrams of Benadryl IV. She out. Yep, went right to bed. Put her on a non-breather. She slept all the way to the hospital. It was great. So, yeah, that does happen. So, a spontaneous pneumo, okay? A pneumothorax is accumulation of air in between the pleural spaces, okay? What happens is, this happens a lot of times because of medical conditions, and this happens in thin, frail white males who smoke. I don't know why. There's no real rhyme or reason to that, but it actually is a thing. And what happens is there's a vacuum that normally is in between the pleural spaces, and that vacuum is lost. So air is escaping into that space. And what happens is, as that air is escaping into that space, it causes compression against the lung. Well, as it's causing that compression against the lung, what's happening? Well, that lung can't fully expand, gas exchange can't take place like it's supposed to. Okay? So as such, this is what you'll see. Okay? The patient will become dyspneic or have continued difficulty breathing. Okay? The breath sounds may be absent on the affected side or very diminished. You'll usually see it start down here in the lower portion, and this is why we check all the lung fields. How many lung fields do we have? 12 that we auscultate. So we check each of these. There's 5 lung regions, but we auscultate 12 points. Let me clarify that. And because of that, like I said, if you have a wound because of it, or this is not a spontaneous pneumo, but an actual, a septic chest wound, what have you, you'll have to plug the exterior and try to reinflate the lung using positive pressure ventilation, i.e. bagging. We do not put these patients on CPAP. So that's the one caveat to that. Whereas normally positive pressure ventilation could be CPAP or bagging. We don't put these patients on CPAP because it'll cause severe lung trauma. Okay. All right. A pleural effusion. This is a collection of fluid outside the lung. It compresses the lung just like that pneumo does. Okay, and it causes the lungs not to properly inflate. This is because of irritation, it could be because of infection, because of CHF that's leaking, or it could be because of cancer, and you could actually have masses outside of there. They always feel better sitting up. So one of the telltale signs that we see with these patients is we always like to ask them, how have you been sleeping? Okay, and if your patient tells you that they've only been able to sleep sitting up, you can usually tell that either a pleural effusion is happening or they're having congestive heart failure. Because when they lay down, they can't breathe because that fluid's covering the alveoli. Okay? All right. So, like I said, that's if you have a patient that's having difficulty breathing, ask them the past couple nights, how have you been sleeping? What position have you been sleeping in? Okay? So, for an airway obstruction, this is what we refer to as a mechanical obstruction. This can be because of vomit, because of foreign body, because of tongue blocking the airway, multiple things. What we're going to do is depending on if it's trauma or not, we're going to open this airway either using a head tilt chin lift or a or a modified jaw thrust. And we're going to suction, 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 suction. Always have suction available and at the ready so you can get this airway back open. That is imperative. If it's a foreign body, we're going to do the Heimlich maneuver until they pass out. As long as, if they're still breathing on their own, kind of moving around, we're going to leave them be. If they're, choking severely and can't breathe and asking for help, then we're going to do the Heimlich. If they pass out, we're doing CPR. Okay? We're doing compression only CPR. Okay? A pulmonary embolism. Okay? This is a clot that circulates through the venous system and actually ends up blocking the pulmonary artery, okay? Which means that blood can't get back to the lungs to be reoxygenated. Circulation may be only partially cut off or maybe completely cut off. If it's completely cut off, you're going to see a patient that goes unresponsive and has something referred to as CAPE cyanosis. What CAPE cyanosis is a purple cape around the chest from the nipple line up to the face, and they'll be purple from the nipple line up. Okay? All right. Very significant decrease in blood flow. The emboli can fragment off. Okay? The emboli can fragment off and cause a blockage, a complete blockage of the pulmonary artery. Okay? Remember, the problem with the pulmonary artery is when that happens, that's carrying deoxygenated blood back to the back to the lungs to get reoxygenated. Okay? So what you're going to see with this patient is you're going to see dyspnea, tachycardia, rapid pulse. You're going to have severe hypoxia. They're going to be cyanotic, like I said, CAPE cyanosis. Okay? You're going to have a quick onset of chest pain, and they're going to have coughing up bloody sputum. Why? Because blood's going to start to back up. So it's going to look like CHF, okay? Pink frothy sputum, and they're going to be spitting up blood.
But that's only with the pulmonary embolism.
Yes.
It's even if you see the frothy sputum, if you see it, they're purple.
Positive pressure ventilation.
Right.
Positive pressure ventilation. You're going to bag the mess out of them and haul tail. Yeah. Okay. hyperventilation. This is somebody that's breathing to the point that the carbon dioxide levels fall. They're blowing